Hi, friends and colleagues. Well, we'll be talking today on subluxated cataract, or what we call is ectopia lentis. Now, as you can see, this is a subluxated cataract, and we know the conditions which can, in our daily practice, are the Marfan syndrome, homocystinuria, spherophakias, and one more common condition that we come across with the subluxated cataract is trauma. Besides this, long-standing pseudoexfoliation, or intraoperative, sometimes you can have as you're doing the surgery, the lens might come out and you have a subluxation. So basically, in this, as you can see in this video, this is a 180 plus subluxated. So let's see how we proceed with this cataract. Now this lens is, already, going upstairs. So as you saw, this is tilted. As we try to put in the side port, you can see I could have punctured that capsule, but we put high molecular viscoelastic as is advocated to start your rexis away from the subluxated area and move towards the rexis, because immediately if you start, then that subluxation can increase. Now we've got to get the right central round rexis. Now this is the most important part of it, and if we can get, we'll be coming to the next video with the modern ways of doing femtocataract, where you can always say that you can get a central round rexis. Now this is 180 plus subluxation. We'd like to stabilize the bag with a longitudinal, it's a vertical traction. Now these are those nice little capsular hooks that you get in the market, and it's available in India. A lot of Indian companies do it. So the whole idea of putting a CTR, now I am one of those surgeons who would like to put the CTR as early as possible, though the dectum is as late as possible, as early as it is required. Now this is a 180 plus subluxation. I want the lens to be in the plane that it should be, so I have got both a vertical and horizontal control of. Now this is a small, the control, the horizontal way the lens should remain, and this is a soft cataract. As you can see, this is a young child of 7 or 8 year old. So now you have to do a tinges. As you can see, I did a bimanual IA, and the removal of those cortex is so easy. You have to do a lateral tangential. Now you can see sometimes that the CTR can come out. We are putting in the IOL, in this case a multipiece IOL, and then I have placed it here. Now once I placed it, I want to remove these hooks and then see, is the lens central? No, I think the lens should move because it was 180 subluxation, 180 degrees. So what I am going to do is anchor this lens. Now anchor this whole bag and the lens. This is very important because I know that there is 180 degrees support available here. Now I'm moving to the other side of and there I'm putting this CT segment. Now this is a IK Ahmed, one who has invented this, and we are going to use 10 ninoprolene suture. Now the long term there is a problem. As you go in, you can have hyphema, and long term there is a difficulty. Sometimes those sutures may erode, and you can have the suture going, and then the whole action of that, the horizontal traction that you are giving, that might go off. So that's one of the issue that we look into our next video. But here, this is the classical way. You're trying it there. I just got a groove there. I don't take a flap, scleral flap groove, and look at how the lens is central, and we have got it in the right place. And look at this central. We can use a bit of pillow pin, so get it. See, the pupil is nice and round, and this would stay for a long time. So the challenges before us in this case was getting the pupil, the rexis centered. Now, in my experience, almost 15 years of subluxated cataract, I could say 50% of cases I could get nice round capsular rexis, and other 50% of cases the capsular rexis went haywire. At times the rexis went beyond the area that I would like you to say, so I had to abandon the surgery. I had to go in for a removal of the whole lens, going for a scleral fixation, and all those things. Plus, the suture that I have used, as you could see, the suture that I have used to, anchor that bag and the lens, that also, at times 12 years down the line, 7 years down the line, they have eroded. Not that the lens fell off. I am yet to have, I think the whole lens, it was totally dislocated with the bag and the capsule. But many a times there's a irregular fibrosis because the suture gives away and you can have problems. So basically, we have to get the capsular exercise in these subluxated lenses and fixate the bag in a long-term fixation. So if these are young children, or Marfan generally do within the age of 8 or 10 or 7, so they have whole life to go. Some material that has to be there, which the subluxation can remain over a period of time, so many years, because we have follow-up as high as 25 to 30 years. The other authors are there, the way they are doing this way. So we have to find a novel way out. Now, this is, you all know, femtolaser cataract surgery is the latest way we are doing cataract surgery. It's an incremental increase in the way, especially removing hard cataracts, PPCs, white cataracts, soft cataracts. They have revolutionized. I mean, your energy level is down, you can do it. And the biggest use that I find is these cases, the subluxated cataracts. Now, what happens? You have to get the rexis right in the center, and it becomes so difficult at times when you're trying to pull those the rexis margin. At times it goes haywire. You can have a rexis runaway, and the control is because there is no counter traction from the zonules. So that's the reason you cannot keep the rexis the way you want it. You want a 5mm rexis. You want it away from at least leaving a 2.5mm away. If the lens is 10mm, 5mm, so you should have 2 to 2.5mm away from the rexis margin till the fornix of the lens. At times it goes away from it, and the problem is you can have the CTRs which could ride over it, and the CTRs can come out if you don't have enough of that area, anterior rexis margin in the subluxate area. So the choice now is having a femtolaser. Now in femtolaser, as you can see, I can position my rexis wherever I want. So this is the subluxated lens margin. So I have positioned my rexis away from it, see, or else it would be centered. So I have positioned it toward the sideway, and look at the result. So I have got enough of that area, and I could have shown some of the areas which are. Now I do put in high molecular weight viscoelastic. Luckily, in this case, the vitreous is not there. In case the vitreous was there, I could have stained it and do it. Look at the. I mean, I have done such a nice capsular exit. It's so central, so you can see it, and easily I can take out. This is a soft cataract. So what I'm doing is putting in high molecular viscoelastic. Look at that. And I thought I'll put a Cioni ring. Then I decided against it. Let me start with the CTR. Now, most of the time, as I said in my earlier case also, I'd like to have the CTR as early as possible, so that I have to be sure my bag is stabilized. And I'm use a listless hook there to stabilize and put the CTR, and again I'm straight away going and anchoring my capsular bag so that it is round and central. It's shifted to the side, so I have got a central, the whole lens is shifted to the center, and this is a soft cataract. I'm doing bimanual IA. I mean, bimanually I can just remove those cortex and the nucleus, whatever is formed. There's hardly any nucleus formed. And then, as I said, I would use tangential movement to remove those cortical fiber from behind the CTR ring. It's very important that how you move it. I put in viscoelastic. I have loosening that capsular bag a little bit, so that I don't have too much of traction as I pull it, as I do sideways movement and pulling it. Here I'm putting a mono EDO lens. So this is a 28-year-old lady who has come all the way, who wants distance and intermediate vision, but had that been there and I had to put SFIL or blue dial, that would not have been possible. But look at it, I just tuck that capsule in there, but the lens is not central. I know that the lens is not center, it will move from it. So here I am doing a groove, a newer way of doing it. I take a 23 gauge trocar, make an opening there. I have done that, I've given a counter traction. And what am I doing? I'm doing this iris hooks. Normally iris hooks that are, I'm trying it and trying to punch it there. Well, it is not punched totally, but then here I am moving that CT segment gradually. I take it in the anterior chamber and in the bag area. I try to put it inside the bag and see, does it stabilize? It's okay. Now I move it away from it. I put it. So I hold it in the railroad technique. I hold it with a microforces from the left side and hold it from the right side and gradually bring out that capsular hook, the long arm of the iris hook rather, and then now gradually maneuver that CT segment right inside the bag. Once I've got that, I pull it enough so that it is in the center there, and then use the tuck method, just a little bit of tuck. I go deep inside the sclera and use a trypan glue as a marker, bend it, and there I just tuck it. I tuck it as much as I can. Now you can control where the lens is. You can use the Purkinje image of your microscope and then see the lens is quite center. You can see that beautiful, the lens in the center. I do bimanual IA, remove it, put in air, look at that, and then I just suture that tenor. I mean, just immediate traction so that it doesn't move across. Suture under the and over the ear. You need not use it. People can use glue, or you can leave it like this. So these are my early cases. What I did was just trying to look at that, and look at the picture immediately after surgery, post-op, one day. So you have that, the hook there, the CT segment there, and it is attached there. So I expect that this should stay, and you have got a nice round capsular axis. This is a mono-EDOF lens, and the patient has 612 near vision to 6.9 part and distance 6.6. Our biometry was right, 612 to 6.6. She's at 38. She's extremely happy. We plan to do the other eye very soon, and obviously with this availability of these, the ways we do it, and the femto laser has definitely revolutionized the way we manage our subluxated cataract, besides our so many other the cataracts that we are managing. So thank you for your patient hearing. If you want to ask any questions, this is we are open, we are on live. Any question that you would like to ask, let's have it. Well, you have asked, there's a question here, what are the potential risks associated with subluxated cataract? Well, if you look at it, subluxated cataract, if it becomes cataractous, well, the lens might ultimately dislocate in the vitreous, it might lose vision. Now, during the surgery, as I said, you can have the capsular axis going away. You can have at any point of time the surgery, the hooks give away and the capsule tears. You might have to abandon the surgery and turn it into a simple scleral fixated IOL, do an ICC and do a scleral fixated IOL. So that's one of the. So there's a question, what is your view on the outcome of phacoemulsification in eyes of subluxated cataracts? Well, my views have been, over the years, as I have, mastered the technique, as I have seen the femto laser, as I've seen the vision, long term, only thing is the earlier long term, when the rexis, when I'm trying to master, the rexis was not central, and those days you could have the fibrosis, the lens shifting to one side, and you could have problem over a period of time. But with the long term stability of the capsule, that can be changed. So what is the mainstay treatment of subluxated cataract in terms of pharmacotherapy and surgery? Now, See, pharmacotherapy as such in early cases when the subluxation is very little, you can, if it is too much away from the central area in an aphakic area, if it is there, you can do just refraction, or if it is too much just cutting the pupillary, you can use pilocarpine in the early days just to have so that the subluxated area doesn't come in the visual field. But otherwise, I mean, there's hardly any role of pharmacotherapy. Wait for the refraction, do the refraction, ultimate refraction, till the child is ready or somebody is ready for surgery. And how far observation was allowed in patient with this condition? So this is this particular patient that we saw at femto was done 3 months back. We are planning the other side, and patient is maintaining the distance and intermediate vision. Other case, the first one, the case that I showed you early, the first case, well, this is already under 4 years follow-up, and we haven't had any problem. The vision is well maintained, and patient can see 6/9 vision with 0.75 diopter spherical correction, and patient is around, as I said, around 28 or 30-year-old. Thank you. Thank you for patient here.